Oral Surgery Conference Case Discussion Group 2. Leader, Esguerra Nima Catrish. Members, Cortez Lenny, Flores Kins, Fuerte Kian, Habate Trisha, Panghilinan Victor, Pineda Sheena Blaze, Rubio Maika Aba, Salvador Emren, and Villanueva Natalia. Our case is a 23-year-old man with extensive carious lesions and root fragments in his maxillary anterior teeth and mandibular molars. Our diagnosis for this case is chronic apical periodontitis secondary to carious lesions, and our treatment plan is multiple tooth extraction. The procedure for extracting multiple teeth at once is a bit more complicated than a simple single tooth extraction. You can live with one tooth without major consequences, but losing several teeth at once requires the jawbone to be reshaped to prepare for a dental bridge or dentures. The materials needed are the personal protective equipment such as gloves, head cap, face mask, and eyewear. For basic instruments, cotton plier, explorer, 2 mouth mirrors, and antiseptic 1% povidone iodine as mouth rinse. Topical anesthesia, 2% lidocaine with 1:100,000 epinephrine. Number 27 gauge short needle, number 30 gauge long needle, aspirating syringe, gauze pad, cotton tip, gum separator, elevators, forceps, curette, bone file, irrigating syringe, 0.9% saline solution, surgical suction tip, needle holder, suture silk, suture needle, and let's begin. First step that we did is the drying of the injection site using cotton gauze for better vision and to make sure that the topical anesthesia will take effect. Next is the application of the topical anesthesia using cotton swab and lidocaine so that it will not be painful for the patient when we insert the needle. After that is the anesthesia induction. The techniques of anesthesia that we used are the inferior alveolar nerve block, long buccal nerve block, and lingual nerve block. The nerves anesthetized are the inferior alveolar nerve, the long buccal nerve, and the lingual nerve. For the inferior alveolar nerve block, with the patient's mouth open maximally, identify the coronoid notch and the pterygomandibular raphe, 3/4 of the anteroposterior distance between these two landmarks, and approximately 6 to 10 millimeters above the occlusal plane is the injection site. For the buccal nerve block, identify the most distal molar tooth on the side to be treated. The tissue just distal and buccal to the last molar tooth is the target area for injection. And lastly, for the lingual nerve block, point of insertion of needle is distal and 6 to 8 mm inferior to the lingual gingival margin of the second lower molar. The barrel of the syringe is placed over the contralateral incisor or canine region, angulated toward the second molar. Once the anesthesia takes effect, we will now proceed with reflecting the tissue attachment from the tooth using a gum separator. We have to make sure that every tissue attachment is removed so that it will be easier for us once we elevate the tooth. During elevation, we use finger guard to protect the patient from any tissue injury caused by the sharp instrument. Also, elevating the tooth first before using forceps makes it easier for us to deliver the tooth and prevents any breakage or chances of breakage of the root. Once the tooth is properly elevated, we can now use the forceps to deliver the tooth out of the socket. In this case, we used forceps number 44 to remove lower root fragments. By the way, the first tooth that we are removing is the tooth number 48. Then we will remove tooth number 47 and lastly tooth number 46. This is to follow the correct sequencing of multiple tooth extraction. Once the tooth is delivered, we will now irrigate the cavity using 0.9% normal saline solution. For teeth number 47 and 46, we repeated the same steps that we did on tooth number 48. We elevated the tooth first before we adapt the forceps and deliver the tooth to make it easier for us and to prevent any fracture of the tooth. We also irrigated it with 0.9% saline solution. After irrigation, we used a curette or a periapical curette to clean the cavity or the extraction site and make sure that there is no debris left. Bone filing is also performed to remove or eliminate rough bony edges, and compression of socket is also done. This is to return the socket to its original form. Lastly, we sutured the mucosa using continuous locking suture technique. Locked sutures have increased tensile strength, therefore they are useful in wounds under moderate tension or in those requiring additional retention. Then, we prescribe the patient with mefenamic acid, 500 mg capsule, 12 caps for 3 days to be taken every 6 hours. After providing prescription to the patient and having him bite on a moistened gauze, we also advised him to replace the gauze after. This is to help control bleeding and promote clotting. Soft and cold diet for 24 hours to avoid irritation and food impaction on the extraction site. We also instruct the patient to avoid drinking using straw and avoid strenuous activity to avoid increase of bleeding. Using a straw places a lot of pressure on the wound healing, which can easily dislodge the blood clot. Instruct the patient to avoid spitting, as spitting also creates pressure in the mouth which may dislodge the blood clot. Cold compress on and off for 15 to 20 minutes within 24 hours. Warm compress on and off for 15 to 20 minutes on the third day. To balance blood circulation, cold compress can decrease swelling and inflammation and help stop bleeding, while warm compress to increase blood flow, and it can reduce pain and speed up the healing process. Do not smoke and drink alcohol for about 5 to 7 days, as it interferes the healing process. Your wound may not clot enough to ensure a quick and complete recovery. Take pain relievers to help reduce pain and inflammation as needed, and also the patient needs to come back after 7 days for recall. During recall, first we checked whether the sutures are intact We also checked for signs of inflammation, presence of bleeding, and we also asked the patient if he had a fever during the last 7 days. Then, we dried the area using cotton gauze so that we can apply topical anesthesia later on. This is to help or ease the pain of the patient from the removal of the suture. Then, using tissue forceps and surgical scissor, we removed the suture one by one. After removing the sutures, we then irrigated it with 0.9% normal saline solution. That's all, and thank you for watching.